This talk is an overview of treatment for ADHD in children and adolescents. I'll teach you the basics of pharmacologic treatment for pediatric ADHD with a simple algorithm. Treatment should begin with monotherapy. Based on their high efficacy, favorable safety and side effect profile, and ease of use, your first choice of ADHD treatment should be a stimulant. Let's review the stimulants in a bit more depth. The two general classes of stimulants are methylphenidate and amphetamine, but within these classes there are multiple different subtypes and formulations. If one class is ineffective, try a stimulant from the other class next. Amphetamine is effective more often than methylphenidate, but methylphenidate is better tolerated, so most treatment guidelines recommend trying methylphenidate first. Extended release or ER stimulants should be used rather than immediate release or IR stimulants, due to ease of dosing, once per day rather than twice per day, and due to more gradual onset and offset of effects, which tends to make the side effects easier to tolerate. ER formulations also have a lower risk of abuse and misuse. Some patients may prefer to try IR before switching to ER to test their tolerance, some may require an additional IR dose in the afternoon, and some may simply prefer the effects of IR formulations. However, in general, when possible, you should convert from IR to ER dosing due to the previously stated benefits. An adequate trial of a stimulant involves at least 1 week at the FDA maximum dose or the maximum tolerated dose. That's all I wanted to say about stimulants, so let's go back to the algorithm. If the stimulants are ineffective or intolerable after adequate trials, then you should next try a norepinephrine reuptake inhibitor, such as atomoxetine. Viloxazine is another NRI, but was only recently FDA approved and likely still unaffordable for many patients. An adequate trial of an NRI involves 6 to 12 weeks at the FDA max or max tolerated dose. Next, try the extended-release alpha-2 agonists, guanfacine and clonidine. Guanfacine should be tried first, due to its superior efficacy and side effect profile. An adequate trial of an alpha-2 agonist involves 1 to 2 weeks at the FDA max or max tolerated dose. Finally, if none of these options are effective or tolerated, then you can try medications that do not have FDA approval for treatment of pediatric ADHD, but have shown some efficacy and can be used off-label. These include the atypical antidepressant bupropion and the tricyclic antidepressants imipramine, desipramine, and nortriptyline. If monotherapy with a stimulant or NRI is partially effective, then you can add one of the extended-release alpha-2 agonists as an adjunct. That's the end of the treatment algorithm, but there are a few points I'd like to conclude with. First, the treatment algorithm for preschool-age children is a little different. First of all, parent management training, or PMT, and school supports, such as an individualized education plan, or IEP, are essential in this age group. Therefore, most treatment guidelines recommend trying PMT and school supports without medications as the first line in treatment for preschool-aged ADHD. If these conservative treatments fail, then medications can be tried, and methylphenidate IR should be the first choice, as preschool-age children may be especially sensitive to stimulant side effects, so trying out the IR formulation first may be better. Also, be aware that most ADHD medications are only FDA approved for ages 6 and older, so most meds would be off-label in preschool-age children. Finally, recall that there are several principles that you should keep in mind when choosing between any psychotropic medications, including safety profile, patient preference, prior trials, ease of use, side effects, secondary benefits, and drug cost. That's the end of this talk. I hope this helps in understanding the pharmacologic treatment for pediatric ADHD. Thank you.